Hello, everybody. It's time to begin today's webinar. Welcome to Advances in Billing Practices for Applied Behavior Analysis, ABA Services. Before we begin, let's go over a few housekeeping items. If you're on the line and have not yet connected to the webinar, click the link in your confirmation email. Your browser may prompt you to download and run a file. When you're connected, you should see the presentation on your screen. If you have questions, you can send them via WebEx's chat function. Please take a moment and find the chat bubble icon near the bottom and center of the webinar screen. You can type and send questions throughout the presentation. We'll compile them and take time at the end for answers. This webinar is being recorded, and a copy will be made available to all attendees after the event. Now it's time to introduce your presenter, Dr. Mirella Peterson. Dr. Mirella Peterson owns and operates a consulting practice devoted to assisting therapeutic providers with insurance contracting, software development, billing, and revenue cycle management activities. She holds a doctorate degree in health administration from Central Michigan University, a master's degree in information systems management from Brigham Young University, and a bachelor's degree in information systems and technologies from Weber State University. Additionally, she holds professional certifications in international health and health information exchange. Now I'll hand it over to Dr. Peterson.
All right, thank you very much for that introduction, Sarah. And today we're going to be talking about ABA codes and what's new. We have recently updated the codes from CPT Level 3 codes to CPT Level 1 codes. And I'll go ahead and describe what that means. If you have questions, please put them in the chat. There are already 3 links in the chat for supplemental resources that we will cover at the end of the webinar. But feel free to enter your questions there as we go. Okay, so a brief description of Category 1 versus Category 3 codes. Category 3 CPT codes are temporary, and they're used for new or emerging services. So typically those are implemented while data is gathered on those services, and the CPT Steering Committee will work towards implementing permanent codes. So for a very long time, we've been operating under what has been known as the T codes, the code set of 0359T through 0373T. Those temporary codes have been replaced by CPT Level 1 codes. And it's important to understand the distinction between the two because quite a bit has changed. So the CPT Level 1 codes are permanent, and they signify the clinical efficacy of services has been documented in research to meet the rigorous AMA guidelines. These are also consistent with current medical practice. There are different rules governing CPT III codes and CPT I codes, and we'll discuss what is fundamentally different between those. So one of the biggest changes here, we wanted more uniform and consistent adherence to descriptors, and we wanted fewer denials of coverage for ABA services on the false premises that it's experimental. ABA services have been around since the 1980s, and there's plenty of empirical evidence to demonstrate the effectiveness of such. But until recently, we haven't had the collection of research available to secure the CPT Level 1 codes. So I'm going to go through what the codes are currently. The new code set is 97151 through 97158. And it's important to note that there are 2 T codes that are included in this code set, and I'll explain why there's still 2 temporary codes. So 97151 is the assessment, and it's to be administered by the physician or other qualified healthcare professional. All of the units in the new codes are 15-minute units, where previously we had some that were 30, some that were 60 minutes. These are all 15-minute units. And you can see the code, the time units, and who attends that service. So for the assessment, it does allow non-face-to-face time. And this is because there's analyzing past data, scoring and interpreting assessments, and preparing the report and treatment plan. So this is the one code that does allow for non-face-to-face time, and that is because it's consistent with other services such as psychology reporting and other assessments that require a significant amount of time to complete and compile results with the patient not present. So this one, it's important to note it can be billed for time that is not face-to-face. 97152 is assisting the assessment within the scope of their practice for technicians. A QHP can substitute for the technician, but a technician within the scope of their practice can assist in certain parts of the assessment. The assessment writing itself, however, must be done under 97151 by the QHP. So it's important to note that there is no billing for non-face-to-face time on 97152 with the technician. The only services a technician can provide under the assessment are face-to-face, and it would be something like functional assessments, biopsychosocial factors, gathering demographic information. They're able to assist in that regard under this code. The third code on this screen regarding assessments is 0362T, and I have had both providers and payers express concern that they're still temporary codes. This particular code, if you'll note, it's attended by the client and 2 or more technicians with the QHP on site or available to assist. This code is used for patients that have severe behaviors, self-injurious behaviors, behaviors that would prevent the assessment from being conducted without an additional technician there. The reason that it's still a T code is because this is probably 10% of the population that would require this service. So it's not that it is an unimportant service, it definitely is, but there just isn't the number of patients at this point or the amount of data for the CPT steering committee to establish a permanent code. So this code is still included. It's very important. There's some factors listed under these bullet points on when you would use that 0362T. So it's a patient that exhibits destructive behavior, requires the assistance of 2 more technicians, completed in an environment that is customized to the patient's behavior, and administered by a physician or QHP who is on site. So they don't have to be available in the room the entire time, but they do have to be available on site if needed. If you have any questions on assessments, please put it in the chat window. I'm going to go ahead and move on to some of these examples. So the CPT steering committee, and I should have mentioned this earlier, these slides I have to give credit to Jenna Minton, who has worked with the CPT steering committee in establishing these codes. And they provided some great examples on when you would use these codes. It's important to note that these examples are just that. They're not intended to be exhaustive or entirely inclusive. They're intended to provide some explanation and context within which you would use these codes. So for example, on the 97151, an initial or reassessment by the QHP. Prior to the appointment, the QHP is going to review the client records, all their medical history, previous assessments, their diagnostic materials, any of those kind of things required, and they're going to gather the materials needed to conduct the assessment depending on which assessments and tests are going to be administered. Then during the session, the QHP is going to conduct a structured interview with the parents, conduct indirect and direct assessments to identify skills, maladaptive behaviors, things like that. So there are indirect assessments that include standardized and non-standardized scales and checklists, and there are direct assessments of adaptive skills that include direct observation and recording of the child's skills in typical everyday situations. Then after that session, all the data from those assessments will be used by the QHP to develop a treatment plan. It's important to note that it's the QHP that develops that treatment plan under the 97151. There can be assistance from a technician under the next code that we will cover. So the example for a 97152, it's the supporting assessment by technician. And again, this is only face-to-face time. So after the QHP has determined that stereotypic behavior is a treatment target and more information is needed to develop appropriate treatment goals, the QHP will direct the technician to observe and record occurrences of behaviors in everyday situations. The technician and QHP will review that information together, the definition of the stereotypical behavior and procedures for observing and administering occurrences of that behavior. So the technician can assist in that regard. Prior to the assessment session, the technician will gather all the materials, data, most recent treatment sessions if they're already in services. During the session, the behavior technician, under the direction of the QHP, will observe, record occurrences of the patient's stereotypic behavior or maladaptive behavior, whatever the goals that were or skills that we're targeting. And after the session, the technician will graph the resulting data. So it's important to note that the billable time is the face-to-face time that the technician is spending, but there are activities that occur prior, during, and after that are included in the pricing for this code. And then here's the temporary code, assessment code 0362T. There are 4 components listed, and they're back on the slide with those bullet points, but you've got to have a safe environment. So prior to, this example is a patient that has severe SIB, self-injurious behaviors. So the QHP completes a risk assessment to determine what safeguards need to be in place in order to conduct the assessment, and gathers the materials and briefs the technicians regarding the behaviors. During the session, in this example, there's 3 technicians. The definition is 2 or more. In this case, 3 technicians work with the patient in a safe environment according to a QHP designed protocol. During each of the functional analysis sessions, the technician collects data on the self-injurious behaviors and communication responses. The second stands closely behind the patient and blocks attempts at SIB. And the third technician carries out the QHP designed functional analysis procedures. The QHP is available on site to closely monitor in case they need to step in and assist the technicians. Afterwards, the technicians record all the results and provide data to the QHP so the QHP can graph and modify assessment protocol. So in this example, this severe level of self-injurious behaviors that would require 3 technicians would be, again, probably 10% of the population, but when it is necessary or when it's medically required, this service is extremely important to get a proper plan in place to keep the patient from escalating to higher levels of care. So I'd really encourage on those cases that are severe enough to require multiple technicians that we engage this code so that we can keep patients from escalating to higher levels of care, and we can get proper protocols, plans in place to reduce those behaviors. So the next set of treatment codes that we're going to talk about is the adaptive behavior treatment codes for the individual client. So a lot of times this will be referred to as the one-on-one treatment services from the technician or the QHP. In the previous code set, we had our codes that were kind of provider specific. They included face-to-face and indirect time for both the technician and the QHP. Under the AMA guidelines, you cannot report any non-face-to-face time. So it's important to note that as we go through this, I'll discuss that further with the 97153 and 155. So the 97153, the reported time is face-to-face time with 1 patient for each 15 minutes. And this is attended by the technician. A QHP may substitute for the technician. So in severe cases or if availability warrants, then you might have a BCBA or a QHP substitute for a technician. But typically this is rendered by a behavior technician or a registered behavior tech. Again, the reported time is face-to-face with 1 patient. However, there are pre and post activities that are required to be completed by the QHP and the technician. 97155 is what we used to call supervision, and now it's adaptive treatment, behavior treatment with protocol modification. The protocol modification is where the QHP, or BCBA, Board Certified Behavior Analyst, is modifying the protocol or supervising the implementation of a plan with a technician. The reportable time on this code now is face-to-face only. Now, it's important to note under the board, the Behavior Analyst Certification Board, BACB, there is indirect time that is required to administer these services. And that indirect time includes reviewing data, adjusting targets, all of those things. So it's important to take into consideration that indirect time when noting that only face-to-face is reportable. The third code listed on the screen, 0373T, is the second temporary code. And again, it's not because it's not efficacious or a viable service, it's because the data is not as available because the less than 10% of the population needs it. But for that part of the population that needs it, it's extremely important. Again, this is a client and 2 or more technicians with the QHP on site. It's for patients who exhibit destructive behavior, needs to be in a customized environment, assistance of 2 or more technicians with the QHP available. They do not need to be in the room, but they do need to be on site and accessible. So this, again, this code will be used for the more severe patients that need additional technicians to gain instructional control and implement the treatment plan. The goal of this service would be to taper off down to where it's sufficient for a single technician to administer services. But in order to control the severe behaviors and maintain safety for the patient and the service providers, it's important that they have access to that for the more severe cases. Some examples. So I love these examples because they help you understand what goes into the prior and after, because the reportable time is face-to-face. So prior to the first implementation of any treatment protocols, the QHP and technician have to review the definitions of the treatment targets and the protocols for addressing each. Meaning you can't send a technician in flying blind. They've got to understand the treatment plan, the targets, the goals, the protocols, so that it can be implemented effectively. So this is done prior to each treatment session. The technician needs to gather materials, review the data, and the notes from the most recent treatment sessions. During the session, the technician will implement the treatment protocols and data collection procedures in the environment that's prescribed, whether it's the family home or community setting or a center. Then after the session, the technician needs to record those notes and summarize what occurred and any aspects of the behavioral definitions or protocols that need to be reviewed by the QHP. Then the QHP will review those graph data from all the treatment sessions weekly so that they can assess the child's progress and determine if the treatment targets are appropriate or if there's a revision needed. Under 97155, a lot of times people will refer to this as the supervision code. It's treatment direction of the technician by the QHP. So essentially it's making sure that the technician is carrying out the treatment plan as prescribed. So prior to the session, the QHP needs to review the data and notes. To promote generalization of treatment gains, they've got to review the modified written protocols and incorporate procedures that build the individual's language, social skills, daily home routines. Again, this is an example. They may have other goals specific to their maladaptive behaviors. During the session, the QHP is going to demonstrate the treatment procedures with the individual while the technician observes. Then the technician will implement the modified treatment protocol, and the QHP observes and provides feedback. So this is not indirect in any way. It's not they're in the vicinity. They are in the room face-to-face with the patient, modifying the treatment protocol or verifying that the administration of the protocol is being done correctly by the technician. After the session, the QHP needs to modify the protocol as indicated based on their observations during the session, and also write a progress note with a plan of action. We went through an example on 0362T. This one is similar, treatment direction by multiple technicians and the 4 components. So prior to this, this example, it gives an example of pica behavior, which is ingesting foreign objects. I think it's a good example, but there are that's just one one of many examples of where you would need treatment direction by multiple technicians. So going with this example of pica behavior, prior to the session, the QHP needs to gather all materials and have a technician carefully inspect the treatment room to make sure there's no potential pica items on the floor. So maintaining safety prior to making sure that the room is safe for the client so they don't ingest something that could be harmful to them. During the session, the QHP demonstrates the modified treatment procedures with the patient while the technician observes. The modified procedures involve one technician presenting the patient with one small preferred food item and one item that resembles a pica item but is not dangerous. On each trial, the 2 items are placed on the table. The second technician is positioned directly behind the patient to provide the patient with gentle physical prompt to pick up and eat the food item. So essentially, they're training the patient to ingest proper food items and not ingest items that could be harmful to them. Because of the nature of that, there would be a requirement for multiple technicians. And the full examples of these will be provided to you. I think this is an example that just illustrates why you would need multiple technicians. Pica behavior is one, self-injurious behavior is another. The goal of these services would be to taper down to a one-on-one technician and not continue for long periods of time with multiple technicians. But in order to maintain safety and proceed with the patient's goals, we do need to have access to multiple technicians for some periods of time for some clients. After this session, the QHP reviews the technician recorded graph data, assesses progress, and determines if the protocols need to be adjusted further, and they write the progress note. So there's been a lot of questions in the industry about what can be billed concurrently, because you know, in comparing to different industries, ABA is quite unique in the way that treatment direction is administered. And the AMA has established that treatment direction, what was previously referred to as supervision, is a separate, distinct service from the direction of the technician or the implementation of the individual treatment. So the codes that can be billed concurrently, 97151, individual treatment by the technician or QHP, is billable concurrently with 97155 by the QHP. It is a separate and distinct service. And so even though both the technician and the QHP are in the room with the patient at the same time, they're performing separate services and distinct functions. So those codes may be billed concurrently. In addition, 97154, group treatment by a technician or QHP, that one we'll go over later in the slides. We haven't covered group treatment codes, but that can also be billed concurrently with 97155 because the QHP may be directing or overseeing the group treatment that a technician is administering. So those also may be billed concurrently under the AMA rules. On 0373T, that's the individual treatment by 2 or more technicians or 2 or more QHPs. There is no additional code for the direction of the technician because it is bundled within that service based on the on-site requirements. So you should never be providers should never be billing 0373T concurrently with 97155. However, 97153 and 97154 can be billed concurrently with the 97155 code. There are some examples of concurrent billing. So in this example, the client has direct treatment with a technician from 9 a.m. to 12 p.m. So there's a 3-hour direct session. The QHP has modified the protocol in the client's program from 11 to 12 p.m. To direct implementation of the modified protocol for the technician. So the billing would be reported the 3 hours under 97153 for the direct treatment, which would be 12 units because we've got 15-minute increments. The 97155 code would be reported for 1 hour of direction of the technician by the QHP, which would be 4 units or 1 hour. So you'll note that the session occurred for 3 hours, 9 a.m. to 12 p.m. 3 hours are reported under 97153, and 1 hour is reported under 97155. So group codes. Group codes are extremely important, especially when you've got individuals that have social goals. And as they are older, one-to-one treatment sometimes is more expensive and less effective when you need social goals. So there is a group adaptive behavior treatment by protocol code. It's administered by a technician under the direction of a QHP. It is face-to-face with 2 or more patients. There are modifiers, and actually you can find those modifiers. I usually look on the Utah Medicaid website. I'll look up the link for that, but there are modifiers based on the number of clients. So some carriers have chosen to price their service for 97154 based on a modifier and the number of clients in the session. So you might have, at a minimum, you've got 2, but you could have up to 6 under the Medicaid modifiers. Now, this is also face-to-face time with, well, as I mentioned, 2 or more patients. 97158 is group adaptive behavior treatment with protocol modification administered by the QHP. So this is 2 or more clients with a QHP. If we've got more severe needs and the QHP needs to administer that, it may be rendered under the 97158 code as opposed to the 97154. It's important to note that the 97158 code is not billable concurrently with 97155 because it is administered by a QHP, whereas 97154 is billable concurrently with 97155 because a QHP may also administer direction during that session. We've got some examples of group sessions, and these again are very similar to the other examples. Prior to the treatment session, the QHP technician review the data and notes, gather materials. During the session, they implement the protocol, and after the session, they record the data, review the data, adjust protocol as necessary. In the example of 97158, it kind of explains a little further why you would have a QHP administer the group session as opposed to a technician under 97154 that we reviewed previously. The QHP includes participation in the group treatment session to focus on peer social skills in the patient's treatment plan. So that's one example. Prior to the QHP is going to review the data. During the QHP, we'll engage each patient briefly to describe their recent social encounters with their peers, what went well, what did not. So you're engaging the peer community to address their social skill goals. And after the session, the QHP will graph and review the data. And then we've got just a few more sets of codes. One is adaptive behavior family treatment guidance. These are so important to make sure that the caregivers are on board with the treatment plan and are following through with the skill acquisition that is done with the provider, that is consistent within the home. So on 97156, it's a caregiver and the QHP. It's again face-to-face time, and it may be with or without the patient present. There are various reasons why you would want the patient there, depending on their age, functional ability, level of engagement, ability to understand their own goals. So this can be done with or without the patient present, and it is done by a QHP. And the intent here is that they're going to offer that behavior treatment guidance to the family so that they can have consistency of services once they've left the clinician. There's also multi-family group adaptive behavior guidance, and this is also administered by a QHP face-to-face, and it's multiple sets of guardians and caregivers. So it would be 2 or more, and again, there's modifiers based on group size that are available, and depending on carrier. Some carriers will allow modifiers and some do not. So the example for 97156, family session by the QHP, again, they're going to review the data, gather materials required, and then during the session, they're going to review the treatment protocol with parents, which involves the use of prompting, reinforcement, basically training the parents to be consistent with the treatment plan that's being administered by the technician or QHP. Afterwards, the QHP is going to graph and review data. An example of 97157 multifamily session, the QHP will invite parents to attend a training session with several other parents. Again, prior to, they're going to review notes, treatment protocol. During the session, they're going to ask each set of parents to identify skills to increase. So you're going to have some collaboration among the parents on what's working and what's not. It's a very effective and often less expensive way to administer that family therapy when you have multiple families in a single session. Afterwards, the QHP is going to write the progress note and plan of action. So some of the common questions that have come up as these codes have been released are listed here. And these, again, are Jenna Minton slides from the CPT Steering Committee. And I'll do my best to answer these, and then we'll open up for questions shortly. So the first question, how is time for ongoing treatment planning captured? So ongoing treatment planning is indirect time. It's not face-to-face with the client. It's the activities that are done before the session and after the session to adjust targets as needed, to review data, graph data, chart data. All of those services are required to implement a cohesive, coherent plan. So how is this time captured under CPT III? This was often reported under the 0368T code, and now it's not allowed. So what I've seen from various carriers, some of them will have a separate code, like an H code or a different code for indirect time. This is a non-standard approach that carriers have implemented in order to allow this ongoing treatment planning to be captured and reimbursed. The board guidelines are approximately, or a minimum of 50% must be face-to-face time. But that leaves another 50% of supervision QHP time that is not reimbursable or not billable, I should say, under the CPT Level 1 codes. So there are 2 approaches. Some have used a non-standard code, either an H code or I've seen a 99089. I've seen various codes used for ongoing treatment planning, but it does cause some complications with coordination of benefits. So for the providers in the room, I would encourage you to work with your carriers to see, do they offer a code for ongoing treatment planning? And for the payers in the room also, if you offer that, then make sure your providers are aware. Now, the other approach and the intention of the CPT Steering Committee was that the pricing for 97153 would include the pre and post activities by the QHP, which is the ongoing treatment planning. So the expectation from the CPT Steering Committee was that when these codes were rolled out, that carriers and providers would work together to adjust their codes, adjust their pricing to capture that pre and post treatment planning activities around the 97153 code. And I have worked with many carriers on this, and some have opted to adjust their fee schedule to incorporate the ongoing treatment planning within the 97153 code, and others, like I said, have a non-standard code. So providers, be sure and check with your carriers on how they're expecting that ongoing treatment planning to be captured and reported, because under the CPT I codes, you cannot report indirect time for anything other than the 97151 assessment code for the plan writing. The next question, can I bill for treatment planning if the patient is in the room? No. So we can't just have providers keeping the patient in the room while they are not engaging with them and working on the treatment plan so that they can count that as billable face-to-face time. The intention for face-to-face time is that it's an active engagement with the patient. So treatment planning with the patient in the room would not be a billable service. Can I bill for supervision of technicians without the client present? Also, this is not a billable service. It must be reported as face-to-face time. So there is an adjustment needed to the fee schedule, whether it's a supplementary code or an adjustment to the rates for those codes to account for that time. But no, you cannot bill for supervision of the technicians when the client is not present. The other question, I guess is the fourth bullet. My payers currently pay for treatment planning under HCPCS code. Am I now limited to only CPT I codes? The answer is no. So those H codes, those HCPCS codes are still valid, and the CPT Steering Committee did encourage providers and payers, if they would like to use those HCPCS codes, to continue to do so. The one caveat that I would add to that, however, is coordination of benefits becomes complicated when we're using a different set of codes. So there's still crosswalking required when you go from primary to secondary. So that is something to consider with supplementary HCPCS codes. Can I use 97151 for ongoing treatment planning work? This has been a big question in the community because this indirect time where you're adjusting your treatment plan, the only code that allows for that indirect time is 97151. However, the intention of 97151 from the CPT Steering Committee has been that that is for assessments and reassessments only and not for ongoing treatment planning. That ongoing treatment planning needs to be captured in the pre and post activities and pricing of the 97153 and 97155 codes and is not reported separately under this 97151. Before I move on to the next slide, I just want to ask if anybody has questions or comments on, since I brought up some common questions, are there questions that anybody would like to put in the chat, or I can put you so that you can ask those? I'll just give you a minute to think through that and see if you've got a question or two.
There are no questions at the moment, but as a quick reminder, you will find your chat button at the bottom and center of your screen.
Thank you so much, Sarah. Okay, so hopefully that means that I've answered everybody's questions, but feel free to chat them in if you have any come up. Okay, so additional information. CPT codes are carrier priced. So they have not done a RUC survey, and the feeling is that it's a little early for a RUC survey because the CPT codes have just come out. That RUC survey is expected to be done sometime in the future, but at this point they are carrier priced. So in the future they might be where there's standard CMS rates and units and guidelines. Right now it's a negotiation with your specific carrier. So this is designed, these are questions, I guess, or advice specifically for providers, but I think it's applicable to payers as well. So preparing for these codes, they were implemented on January 1st, 2019, and I hope the implementation has gone fairly smoothly. Some have been easier than others, but we all need to be educated, payers and providers both. We need to know about the new codes, how to implement them. There's a code conversion table that I will share in just a minute. It's in your chat window, actually. It's the CPT code crosswalk. that gives you information about the previous CPT III codes and how they map to the CPT Level 1 codes. There's a BACB-ASD treatment guideline that I put into the chat window as well. And then obtain accurate MUEs. MUEs are medically unnecessary edits for new codes. I've been working with different payers to establish what those are because the MUEs were based off of prior codes and units. But definitely ask about MUEs because you might be getting denials as a provider when the MUEs just need to be adjusted. So contracts need to be reviewed. We need to know payer policies and requirements for medical necessity. And we need to make sure that we're on the same page with what is covered. How do we bill the indirect time? How do we make sure that we're getting reimbursed for the services that are being rendered under the new set of codes because they are different. I'm going to pause right there because I've got a question in the chat window. It says, I had a question on 97153 and 97155. If I bill the time for 97153 as 2 p.m. to 5 p.m., and I bill the 97155 as 4 p.m. to 5 p.m., my system won't let me do that concurrently. It will tell me I cannot provide two services at the same time. Is there any way around this? Excellent question. So I'm unfamiliar with your system. I'm happy to talk to you about that, but if you want to chat what system you're using, we can talk about it. What I would do is go back to your system provider and tell them that you have to be able to bill those at the same time. So this seems like a limitation within your software, and that should be rectified, especially if they serve multiple ABA providers. It needs to be able to accommodate the ABA standards. So I would definitely contact your software provider and ask for a fix on that right away. Okay, so back to what to do to prepare, ask questions, engage in conversations. And Adam, you brought up a great point here that you also need to engage your software provider. If they're not able to bill the way that the new codes are required to be billed, then that's going to be a problem for you. So definitely engage your carriers, your providers, your software vendors so that you can build these codes and maintain reimbursement for your services. So third bullet point makes me a little uneasy, but they were clear to prepare for a disruption to revenue. And I have seen this. It takes about a quarter for payers to update their EMRs after the new codes are released on January 1st. And so if you are experiencing a delay in reimbursement, I know that I have several carriers that have not yet loaded the new codes. So everything we've been submitting has come back as denied, and they're working on it. We're working together. I would encourage you to be patient. I know it gets frustrating sometimes, but I think everybody's working within a very tight time frame when these were released. So hopefully a disruption to revenue is not too extreme or too lengthy. And as we enter second quarter, hopefully that resolves. If you continue to have disruption to revenue, definitely engage your provider relations representative to get those resolved so that you can continue services and providing for your clients. Okay, calculate the value or rates for your services. Because these are carrier priced, it's important as a payer that you understand the overhead, expenses, technology, liability insurance, all of those things, so that you know how to price your services. Make sure that you talk to your payers and help them understand, you know, this indirect time that used to be billable and is no longer billable. How do we go ahead and make sure that we achieve net neutral with the prior agreement so that you can continue serving their members? And I've had a lot of success with payers when we talk through this and work the numbers. But you got to do your homework. You need to know your numbers as well, and so that it's a very fact-based conversation to make sure that your reimbursement patterns stay consistent with the new codes. Okay, additional resources. So there's the code conversion table, which is in your chat window. There also is a CPT assistant article. You can order that through the AMA. And then there's a supplemental guidance. I'm going to pull that document over here. And this document right here is extremely helpful. I've used it with both payers and providers to help them understand the concurrent billing situation that is somewhat unique, gives the pre and post Q&A examples. This is a very thorough document, so I would very much encourage you to go through the Q&As on here. And it gives the concurrent billing overview. Basically, the examples that are in the slides are also in this document. And it gives you it's a public link endorsed by the major organizations involved in this, so that you can work with your payers, that it's not just your opinion or what's coming from you, but it's coming from the CPT steering committee and the payers that are, the players that are involved in this. So I'd encourage you to look up the supplemental guidance on interpreting and applying those 2019 codes. This is the crosswalk that we discussed. It's a little small on this window, but it's very helpful because it tells you what those HCPCS codes are, what the prior code under CPT III, and what the current CPT I code is. And then it explains this treatment planning is bundled with services above and below, which is reflective of the pricing adjustment that you'll need to work with your carriers on to make sure that your indirect time is covered as well. And then this document, providers in the room should be very familiar with this. Funders as well. This is a practice guideline for healthcare funders and managers, and it gives the guidelines for ABA and what services are rendered and which services are face-to-face versus which services are indirect. I reached out to Jenna Minton to see if the payer packet is ready. At the time that these slides were released, it was in production, but it contains a model coverage policy, a template to payers, evaluation crosswalk, some really useful information for payers. Once I get a hold of that, I can distribute that. It's got supplemental coding guidance as well, so that CPT assistant article with clinical examples. So that's the end of my presentation. I'd like to just see if there's any other questions from anybody in the group.
Thank you, Dr. Peterson. I'm not seeing any questions come in. Perhaps what we can do is we can stop the recording at this time and we can hang around for an extra couple of minutes so that if people think of additional questions, we can still get those answered.
All right, thank you very much, Sarah. I'll just hang around for a minute. If you have no questions, feel free to drop off, and feel free to email me if you have any other questions come up in the future.
If you don't have any questions and you feel like you've gotten what you were looking for from today's presentation, then we thank you for your attendance and we hope that you have a fantastic rest of the day.